cervical cancer according to Tumor Editorial Board of WHO, pathological classification of commercial carcinoma as the HPV associated, HPV independent, and pathological classification of adenocarcinoma according to WHO, HPV associated are glandular, mucinous type, and mucinous. HPV independent adenocarcinoma are gastric type, clear cell type, mesonephric type, and endometrioid type. Endometrioid type is very important because endometrioid type of adenocarcinoma of the endometrium should be differentiated from the endometrioid type of cervical cancer. Most of the researchers recognize the existence of HPV independent cervical cancer. Worldwide, its incidence is 5.5 to 11%. Meta-analysis, I don't want to, no. There is the downtrend in the HPV negativity. Why this downtrend? Improvement in the HPV testing, non-cervical cancer misclassification. Recently, by using next generation sequencing, only 5% of all cervical cancer were found to be HPV negative. Reason why this HPV negative? There are several maybe cause. Exact mechanism is unclear. Most researchers consider the mutation in the tumor-associated genes and misclassification. There may be misclassification of non-cervical cancer, that is endometrial adenocarcinoma, vaginal carcinoma may be misclassified as cervical cancer, and that may be HPV negative. 3.7% of the cervical cancer may be metastatic, and that may be HPV negative. False negative HPV test result may be due to latent HPV infection, and false negative result may be loss of HPV fragments during integration of cervical epithelium. Cervical cancer caused by non-high risk HPV. Prognosis, this is a table of prognosis. It is low prognosis, and this is the table where the HPV-independent cervical cancer report. There are a lot of reports about the HPV-negative cervical cancers. In conclusion, I like to put some questions to the audiences, whether we should proceed to do molecular test in all the cervical cancer to identify the HPV-negative cervical cancer, whether it will be cost effective, and whether we can do molecular test on adenocarcinoma only, and whether we should critically analyze the cases before doing molecular test for HPV detection. Thank you very much for your patience hearing.
Thank you, Madam, for your didactic presentation on the relationship of cervical cancer with human papilloma virus. Madam, feel free to make comment from your seat.
Hello. Shona jay? Assalamu alaikum. Ami Professor Firdausi Begum. After listening to Professor Sabira Khatun, I am totally confused. Basically, she has given so much to us today. And I think the key points are, for the specialists like us, is, yes, we are thinking about HPV virus, but that may not be the cause for 100%. So we have to keep that at the back of the mind. Yes, we are going for cervical cancer screening, vaccination, hopefully. We're going to cover young girls, and that shows the projection from others that in 90 years we are going to sort of push that virus downwards from cervical cancer. But this has to be kept in mind. And I have taken few notes, and those are, I think, few of the things very, very important for us, especially the specialists, that the oncogene, what is there at molecular level. The vaccine, how it's become effective. We know that HPV virus 16 and 18 is causing 70%, but we are going to expect coverage of 100%, almost 100% through this, because we are using cervix here, not the quadrivalent. But as we learned from our other speakers, that is going to better coverage because of other things which that vaccine has. So The virus, it infects people. We know the high-risk patients who are going to be affected, but it doesn't persist. So 10% persistence, which for a long time causes cervical cancer. So it's a complex issue, very, very complex issue. We have to be understanding this, and thank you, Professor Sabira Khatun, for making us to know more and to be more confused. Thank you so much.
Thank you, Madam, for your very important highlights and concise comments. Now I request Professor Dr. Rehana Parveen, Madam. She is the Senior Consultant of Gynecological Oncology Department of Scar Hospital and former Head of the Department of Gynecological Oncology, National Institute of Cancer Research and Hospital. She will be talking on management of high-grade intraepithelial lesions of cervix. Please, Madam.
Respected chairpersons, and the dear audience, Assalamu alaikum and good morning. I will talk on management of high-grade cervical intraepithelial lesion. We know that cervical cancer is preventable because it has a long precancerous lesion period which can be detected accurately by screening test and can be successfully treated with relatively simple techniques. And it is alarming that incidence of CIN has been increasing in the last decades, especially in young women. And in developed countries, the reported CIN-2-3 incident rate is 8.1 per thousand in the 25 to 29 years age group, and the highest incidence observed in the age group 25 to 29 years. The lower anogenital squamous terminology recommended in 2012 the two-tier CIN classification, that LCIL and HCIL, rather than three-tier classification CIN 1, 2, and 3. It is recommended that HCIL is specified as HCIL CIN 2 or HCCIN 3, and HCIL CIN 2 is further specified as whether P16 positive or P16 negative, because P16 positive behaves as CIN 3 and P16 negative behaves as CIN 1, and management is also different. Spontaneous regression occurs if the case is left untreated under observation. And it has been found that there is 30 to 50% cases of regression in CIN2 and 30% regression in CIN3. But these intraepithelial lesions also progress to invasive cancer. In 5% of cases, CIN2 progress, and in 14 to 31% of cases, CIN3 progress. But there is higher regression rates of untreated high-grade intraepithelial lesions, especially in young women less than 25 years of age and during pregnancy. But age-appropriate treatment of cervical precancerous lesions is needed. Why? For effective cervical cancer control, while avoiding overtreatment and related health risks. Yes, HCIL can be managed both by treatment and also observation. And treatment may be excision, ablation, or medical treatment. Choosing the best treatment for HCIL depends on age of the patient, extent of the lesion, availability of the treatment and professional expertise, plan to become pregnant in future or are currently pregnant, and compliance of the patient. 2019 ASCCP management consensus guideline is risk-based and depends on current screening test results and presence of precancerous lesions. But treatment guidelines are separate for women younger than 25 years of age, those from 25 years age and older. Now, what is treatment of high-grade squamous abnormalities? If histological HCIL cannot be specified as CIN 2 or 3, 2019 management guidelines says that treatment is preferred. But if histological HSIL is specified as CIN3, treatment, that is CIN, because treatment is recommended and observation is unacceptable except during pregnancy. Because CIN3 is considered an immediate cancer precursor. But when HSIL is specified as CIN2, in women older than 25 years, treatment is preferred, but observation is acceptable. Where future pregnancy is desirable, observation at 6-month interval for 2 years by colposcopy and HPV test, provided that squamocolumnar junction is visible and CIN2 not identified on endocervical curettage. And if CIN persists for 2 years, treatment is recommended. Women younger than 25 years have higher rates of regression and lower risk to progression to invasive cancer. So observation is preferred here and treatment is acceptable. And in this group, observation includes colposcopy and cytology at 6 months interval. And if CIN2 persists for a period of 2 years, treatment is recommended. But if HSIL is not specified as CIN2, for women older than 25 years, treatment is preferred, but observation is acceptable, and observation at 6 monthly interval. For women less than 25 years, observation or treatment both are acceptable, and observation by colposcopy and cytology. This trial was, this is a review article. It was published in 2018, and the result shows the clinical course of untreated cervical intraepithelial neoplasia grade 2. It shows that in women aged less than 30 years of age, regression rate of CIN2 was 60% and persistent rate 23% and progression to CIN3 11%. Most CIN2 lesions in women less than 30 years of age regress spontaneously. So active surveillance rather than immediate treatment is therefore justified, especially in women who are likely to adhere to monitoring. This paper was published in 2023, and it shows regression rate of high-grade cervical intraepithelial lesions in women younger than 25 years. The incidence and clinical course of CIN2-3 are age-dependent, and CIN3 had a regression rate of 29%, especially in women who were HPV vaccinated and those who cleared their HPV infection. And expectative close follow-up every 3 to 4 months in women with CIN3 younger than 25 is important. This paper was published in 2018, and it shows outcomes of conservative management of high-grade squamous intraepithelial lesions in young women. The graph shows that with passage of time, the progression to normal of the CIN2 increases. But progression is increased when CIN2 is associated with HPV 16 and 18 negative. But when HPV 16 and 18 is positive, the clearance rate is little lower. And this graph shows that progression of CIN2 to CIN3 is much less. Now treatment. The 2019 management guideline recommends the following treatments. Excisional treatment is preferred. Treatment with ablation is acceptable. WHO recommends LEAP over cryotherapy in setting where LEAP is available and accessible. And excisional therapy consists of LEAP, cold knife conization, laser cone biopsy. Ablation therapy includes cryotherapy, thermocoagulation, laser ablation. Topical agents are unacceptable for treatment of HSIL outside clinical trials. And hysterectomy is unacceptable as primary therapy solely for the treatment of HSIL. If we consider LEAP, it has benefit of providing a histological specimen of a small volume, and it provides information on margin status, a predictor of CIN2 persistence or recurrence, and it can be done when squamocolumnar junction is not fully visualized. But cold knife conization can be done in endocervical involvement and suspected invasion, and it also provides histological specimen, but the volume is larger, and so it is associated with increased incidence of adverse pregnancy outcome. Risk of preterm birth after treatment for cervical intraepithelial neoplasia. A significant proportion of women under than 25 years undergo unnecessary treatment and exposed to long-term risks like increased premature rupture of membrane, preterm labor, low birth weight baby, and psychological stress. This paper shows effective destruction of cervical interepithelial neoplasia CIN3 by using cold coagulator. The primary success rate was 95% in 1 year and 92% in 5 years. The rates of abortion, preterm, or operative delivery were not increased in subsequent 226 pregnancies. This meta-analysis shows the efficacy of cold coagulation as a treatment method. The cure rate was 96% for CIN1, 95% for CIN2-3 disease. Side effects and adverse effects were infrequent, and fertility was not impaired. And it shows that CIN cure rate with thermocoagulation is comparable to excisional and other ablative procedures. And it is suitable for use in low resource limited settings and as well as young women who desire future pregnancy. This systematic review compares the benefits and harms of cryotherapy, lip, and cold knife conization. Recurrence, it was found that recurrence rate was 5.3 after cryotherapy or lip and 1.4% after cold knife conization in 12 months period. And there was little or no difference in frequency of complications after lip or cryotherapy, but occurred more often after cold knife conization. And premature delivery is most common with cold knife conization, but it also occurs after lip and cryotherapy, but with less frequency. And lip is preferred over cold knife conization. Adverse obstetric outcomes after local treatment of cervical pre-invasive lesions. The techniques which are associated with removing or ablating more tissue were associated with worse outcomes. Compared with no treatment, the risk of preterm birth was higher in women who had undergone more than one treatment and where in the cone depth was increased. The result shows that when cone depth increases, there is increase in relative risk of preterm birth. When the cone depth is less than 10 millimeter, the relative risk is 1.54. When the cone depth is more than 10 millimeter, it is 1.93. And when it is more than 15, it is 2.77. The pregnancy and severity of adverse sequelae increases with increasing cone depth. When histological HCL is diagnosed during pregnancy, surveillance is with colposcopy and cytology is preferred every 12 to 24 weeks. Treatment of histological HCL during pregnancy is not recommended. And deferring colposcopy till 4 weeks postpartum is acceptable. This randomized trial shows topical Imiquimod application in high-grade lesions. For the patients were treated with Imiquimod cream for 12 weeks and followed by LEAP. And there was histological regression 61%, surgical margins negative 95%, and rates of adverse events 74%. Adverse events were mild, but 3 cases had vaginal ulcer and moderate pelvic pain. And this randomized trial compares conservative treatment with Imiquimod with LEDs with a large lip excision. And in the subgroup analysis of CIN2 P16 plus patients, treatment with Imiquimod was not inferior to large lip excision, but local side effects were more with Imiquimod. And so they concluded that the success rate was comparable between the two treatment modalities, and due to the prevalence of side effect, the treatment complication with Imiquimod use may present a clinical important issue. This clinical trial was published in 2016, and they used lopimune application in HPV positive high-grade lesions. And then after 12 months, they evaluated the patients with HPV DNA test and cervical biopsy. And it was found that the HPV was no longer detected in 52% cases, no dysplasia 63% cases, and combined positive response 81%. But these results demonstrate the potential of lopimune as a self-applied therapy for HPV infection and related cervical lesions. There was no serious adverse events. This study indicates that further trials are clearly justified to define optimal regimes and the overall benefits of this therapy. So take-home message is treatment of CIN3 is recommended, but observation may be considered in young women than 25 years due to higher regression rate. Cold coagulation can be safely used in women who desire for pregnancy and is also preferable for low and middle income countries. And CIN2 may be managed conservatively in young women, avoiding overtreatment provided vigorous monitoring is possible. And treatment with imiquimod is non-inferior than surgical management of CIN2, so can be considered in younger women and in persistent disease after LEEP, but with close monitoring. And cold knife conization and LEEP with higher cervical tissue volume should be avoided in women who desire for pregnancy. Thank you.
Thank you, madam, for your very informative presentation on management of high-grade intraepithelial lesions of cervix. Now I request Professor Ranjit Mandal, sir, to say few words on her presentation.
Few words only. Yeah, it's a fantastic presentation. And the topic is also very nice because in the perspective of cervical cancer prevention, treatment for the high-grade lesion is mandatory. And now, which high-grade lesions to be treated, that's also very important. The one gray zone is the CIN2. Though it is believed that CIN2 and 3 are consisting of high-grade lesion, but not all CIN2 is high-grade lesion. It is only the P16 positive CIN2. That means you need to do the ISC when you are suspecting CIN2. So you need to recategorize CIN2 again before the treatment is offered, when it's absolutely safe. In fact, all CIN2 in our Indian or Bangladeshi subcontinent perspective, all CIN cases should be treated because we know that they are very, they are poor risk for poor follow-up group. So in that occasion, all CIN should be treated. Whenever you find a lesion, because to prevent cervical cancer, whenever you find a lesion, it has to be treated. So that is a very dogmatic statement, but it is true in a country perspective. And all CIN2 does not require treatment. Only the P16 positive CIN2 should be treated. And P16 positive CIN2 and CIN3 must be treated. Because if you don't treat all these two conditions, they are destined to develop cancer in due course of time. So, very important, you have highlighted the follow-up also. The follow-up is very important. And the screening will never be successful if you don't treat all those cases, screen-positive cases. So, in the lesson is, whenever there is a screen-positive cases, you need to treat the patient. You need to treat the disease, you need to treat the condition, depending upon the resources available. If the condition fulfills for local ablation, you do the local ablative method, or if the patient is not suitable for local ablation, if you have the facility for excisional method, go for excisional method without thinking as a second thought, because you have to prevent the cervical cancer in your country. That's the message which you want to give. Thank you. Thank you, madam, for your
Thank you, sir, for your valuable comment. Now, I would like to request Dr. Sandeep Sevlikar, Head Medical, Scientific and Regulatory Affairs, Roche Diagnostics, India. Sir, please.
Thank you for the kind introduction and good morning. At the outset, I would like to thank Dr. Ashwinasa madam and organizing committee for giving me this an opportunity. Now, I think after listening to all the immunology experts who really touched upon the various aspects of cervical cancer, from vaccine to screening and in special population and also the management part, but equally important about how really we can ramp up the screening coverage or increase the access to the screening modality. I think that applicable to the vaccine as well as for the secondary prevention, that is screening as well. Now we see just from our Asian perspective, and we relate our data to the global incidence, that we are actually contributing to the max when it comes to, it's worrisome data, like almost more than 50% contribute when it comes to incidence, when it comes to death, or it comes to 5 years prevalence as well. So I think that's where really important, like how really we can make this entire cervical cancer screening program more accessible, more affordable, and more where I think we can touch the majority of the points where really we can address the various issues that we discussed in earlier sessions as well. I think this point, I think we really elaborated well, and sir also mentioned about like why every stage is very important, but equally important we have to keep in the mind that almost 97% of infections regress back to the earlier stage, but equally important like to watch the positivity rate at each stage, and then I think we can take the very calculative step. So why I'm touching these points is like now into era of advanced technology, we in the era of like a lot of things improved over the period of time, including the logistics, including the various aspects when it comes to screening program. I think these points also will help us drive really defining the right strategy for the cervical cancer screening program. So now WHO really coming up with really aggressive campaign against the cervical cancer, and we already discussed a lot on various forums like what could be the right strategy for vaccinations when it comes to screening, secondary preventions, as well as management as well. And so that's where if you see, Madam already covered like 70%, like at least 2 times in a lifetime, like at least age of 35 or 45 years. If you use a high performance test, I think that will solve the purpose. And if you see the HPV in totality, right, it actually covers the 20 years of horizon if you just apply like 35 or 45 years. But that's also a part of WHO guideline as well. So now when it comes to any cervical cancer screening program, so what are exactly the expectations from while choosing the test or implementation of the program while adopting the various strategies. So when it comes to really the routine screening, I think the expectation the test should have very high negative predictive value, very high sensitivity, and drive the screening interval, right? So I just was going through the one of the poster presentations here, right? So I think we touched upon the various aspects of awareness, social barriers, and all those things. So equally important, like how we use the test that really address various challenges from education, awareness, and the implementation purpose. So idea is not to really miss any woman who has positive, not and to rule out women with that confidence, so that should have covers, the test should have the high negative predictive value as well. So when it comes to diagnosis or treat diseases, I think we touched upon these aspects in the management as well. Should have the which are the tests we are using, whether it's the P16 or Ki67 or P16 histology, that should have very positive predictive value, high specificity, and drives the intervention protocol as well. So we have realized over the period of time, PAP has done the great job in last 5 to 7 decades reducing the cervical cancer burden, but still long way to go where we realize from the various data points that we come across. So, so now this is the topic I thought of like sharing with you, like now how we can really drives various cervical cancer program when it comes to addressing the various needs that we face implementation of any cervical program in the region, right? So what's our expectation? Like the program should be risk-based. That really help us, allows women who test negative to safely exit the routine screening, round of screening. So we test upon every 5 years in a general population, every 3 years in HIV infected women as well, right? So that's most important, right? Ruling out with that confidence, so women can easily exit to the routine screening as well. So disease focused triage, and I think we discussed a lot on screen triage and test, right? So the informations that we are getting at the first time, the objective information that really help us minimizing unnecessary intervention, allows natural clearance of transient infections, avoids progression of cancer, and preserve fertility. And I think these points we already touched in earlier presentation as well. Actionable results in the first screening round, because one of the challenges that we face in any program, and particularly in cervical cancer, is loss to follow-up, right? So I think if you get the information very at the first step, during the first screening step, that we can put the right intervention step there and there only. So that's most important. That really help us also increases the efficiency and the safety of the overall program as well. So most important now the scalable, as Madam just mentioned about, even if like if we take the age group more than 30 is almost 30 million, but if we just concentrate on 35 to 45 million, 35 to 45 years, it's a 14 million per population. So I think really we have to really see like how we can scale up the program to reach to the maximum. I think that's most important. And nevertheless, I think everyone agrees that should be cost effective. I think that's cost effective to the government who is running program. If in a private setup, that's affordable to the or the out-of-pocket expenses as well. So now in last like a couple of decades, a lot of evidence is coming why now it's moving from cytology-based testing to HPV. I think various incidents showed that the sensitivity increased almost by 36% by using for HPV DNA test compared to PAP test. And I think that's most important. And why HPV DNA test? I think most likely the bigger objective is not to miss anyone who actually having SIN2 level grading. And I think sir just touched upon this aspect, like why SIN2 is very critical stage. And I think, and that's where the, not to miss any woman having SIN2, but also having the progressive stage as well. So the whole momentum started, I think, in around 2010 when a lot of studies coming into the picture, and I think there's Athena studies, one of the landmark studies. Based on that, US FDA approved the first HPV DNA test for as a primary screening test as well. Most important now, why we're talking about the advanced technology, and there is always a doubt when it comes to HPV DNA test. Can this test detect each and every woman having HPV infection? No, that's not the case. The system developed in such a way that with the advanced technology that we really moved away from the analytical sensitivity to the clinical sensitivity. So the detection levels fixed in such a way that will not miss any woman having the SIN2 level grading. So the Cobas HPV test, actually most important also the genotyping information as well. And I think ma'am also covered the aspects of the 16-18 contributing to the 18. Also important why the actionable results itself, because now we have to don't get into the situation like false positive or false negative results as well. So this advanced technology taking care of those aspects as well. Now when we want to scale up the program, I think equally important about how we can overcome the logistics challenges as well, right? So the medium that available now that can be stored up to 6 months in a room temperature can be transported easily to the central lab without having any problem like cold storage or cold shipments as well. So that's most important. So I'll just skip these slides. The Athena study, what exactly showed is showing the 92% sensitivity against the 56% or 53% sensitivity, the stat. Now, most other important now, why the 21st century we have to address various aspects is the one of the social barrier as well. Now, if you see the lot of evidences now coming, now we're also receiving the regulatory approvals as well for self-sampling. I think that will really help us overcome the challenges that usually we face while doing the cervical cancer screening program as well. And I think that's most important. Really empower women to come forward for the cervical cancer screening and play a bigger role in eliminating cancer as well. Most important, I think, doing self-sampling is easier to say, but the education to the woman is equally important now, how to take the samples as well, because now we have enough data about like the cervical cancer, cervical sampling versus vaginal sampling, but I think education is equally important. That's where the healthcare assisted self-sampling is most important. WHO already moved. We already discussed and we touched upon these aspects. Out of 7 algorithms, where now HPV DNA test considered as a primary screening in 5 algorithms as well. Various guidelines endorse now HPV DNA test as a primary screening modality. And that's where really we have to see how best we can ramp up the overall cervical screening programs using the centralization model as well as adopting the HPV DNA test. World is moving slowly, steadily. This is little older slide, but quite a few of countries now adopted HPV test as a primary screening tool in a pilot studies. Countries like Australia, they are way ahead of us when it comes to national screening program. But I think nevertheless, we are taking right steps to more in those directions to make this program more affordable and accessible to the wider population. So I'll end up my presentation the same. I think is now HPV address all these points. I think yes, I think really help us to put in a risk-based program, help us very information, giving the actionable information in the very first steps itself. Scalable, yes, now this automation can do thousands of tests in a day if you really want to scale up. And definitely as we start adopting it, definitely this test will be cost effective. And when it comes to health economic analysis, I think there are enough data where shows HPV is more cost effective when it comes to comparing with the VI or PAP. Thank you so much.
Thank you, sir, for highlighting HPV DNA test, which is the ultimate test of cervical cancer screening in 21st century. Now, I would like to request Professor Ranjit Mondal, sir, to make comment.
Thank you. Thank you, Dr. Sandeep, for your nice presentation. 20 years or 22 years back, when you started beginning the journey for this cancer screening, we were the promoters of VIA. Because IARC and Sankar was behind us to go for VIA. And at that time also, we, because of our research background, we were also doing HPV testing just for the competition and to establish that VIA is a good test. We have established that VIA is a good test, and accordingly, many of the countries, including this country, has adopted. In our country also, national program is based on VIA. And this country has also adopted VIA and successfully conducting the VIA, unlike ours. They are successfully conducting VIA, and they are probably, they are introducing the vaccine program, single dose vaccine. That's also very important. Very few countries in this world have started adopting the single dose vaccination, which the Bangladesh is adopting. That's a very important thing. Second thing is HPV DNA testing. We were initially doing the HPV DNA testing by provider collected sampling, but with reports coming in and based on the the personnel and other COVID situation perspective, we started going for self-sampling. This is very true with COVID, this COVAS testing or other HPV DNA testing. Yes, it is equally sensitive and equally effective. And there are many reports which says that self-sampling is probably the future of cervical cancer screening in the world. And it should be adopted as the primary screening because in health economic perspective, it is even more cost effective than adopting the VIA. When you are going to include the whole country under screening perspective. So it will be the ultimate future. The two future things: HPV HPV based screening program as a primary test and vaccination. If these two things can combine together, probably we'll be able to eliminate the cancer, as WHO also said the same story. Thank you very much for a nice presentation, and thank you for giving me the opportunity to chair the session. Thank you, madam.
Thank you, sir, for your valuable comments. Now I request Mr. Lincoln. He's the implementer of District Health Information System 2. He is from Director General Health Services. Mr. Lincoln, to present his data.
Any question?
Assalamu alaikum. Good morning. Good morning, ladies and gentlemen. My name is Sheikh MD Najimuddin Lincoln. I think if I speak in Bangla, there will no problem. So it's a technical, I mean, IT technical session. So I will just take your time, maximum 5 to 6 minutes. So let's start. Okay. আমরা একটা ওয়েবসাইট ডেভেলপ করছি যেটা আসলে এই প্রজেক্টটাকে আসলে ফোকাস করার জন্য, যেটা আসলে মেইনলি এই প্রজেক্টের যত অ্যাক্টিভিটিগুলো আছে যেটা আপনার মিনিস্ট্রি থেকে প্রজেক্টের হয়ে অ্যাক্টিভিটিগুলো সম্পাদন করা হয় সেটার উপর ভিত্তি করে আর কি। সো এইটা হচ্ছে গিয়ে এই ওয়েবসাইটের একটা ল্যান্ডিং পেজ বা মেইন পেজ, যেটা আপনারা আসলে পাবেন হচ্ছে যদি এই সাইটটা ব্রাউজ করেন। আমি কিউআর কোড এবং অ্যাড্রেস দিয়ে দিয়েছি। সো এইটা হচ্ছে গিয়ে আমাদের ওয়েবসাইটের অ্যাড্রেস, যেটা অলরেডি আন্ডার ডেভেলপমেন্ট আছে, এখনও কাজ চলছে। হয়তো আমরা খুব শীঘ্রই উইদিন নেক্সট 2 to 3 উইকসের মধ্যে এটা ফাইনাল করে ফেলবো। সো এইটা হচ্ছে গিয়ে আমাদের ড্যাশবোর্ড, যেটাতে আসলে মূলত প্রজেক্টের আইটি রিলেটেড অ্যাক্টিভিটিগুলো অর্থাৎ ডেটাগুলোকে রিফ্লেক্ট করা হচ্ছে, যেখানে গেলে আপনি উইদাউট এনি পাসওয়ার্ড এখানে ডেটাগুলো দেখতে পাবেন। আসলে আপনারা হয়তো কাজ করছেন অনেকে, বা আপনাদের ফিল্ডের যারা স্টাফরা আছে তারা কাজ করছে, তারা আসলে সফটওয়্যার সম্বন্ধে জানে। আমরা যারা ডক্টর আছি হয়তো অনেকেরই কাছেই এই ইউজার নেম পাসওয়ার্ডগুলো থাকে না। সো এইখানে গেলে আপনি আসলে ইউজার নেম পাসওয়ার্ড ছাড়াই যে কোনো ধরনের ডেটা ভায়া এবং সিবি রিলেটেড এবং কল্পোস্কোপি প্লাস হচ্ছে ব্রেস্ট ক্যান্সার রিলেটেড ডেটাগুলোকে এখানে উইদাউট পাসওয়ার্ড হচ্ছে কি অ্যাক্সেস করতে পারবেন। আচ্ছা, সো আমি এখন খুব দ্রুত হচ্ছে গিয়ে ওয়েবসাইটগুলো এবং আমাদের ড্যাশবোর্ডগুলো দেখিয়ে দিই। এটা হচ্ছে আমাদের ওয়েবসাইটের প্রথম পেজটা, এবং এখানে মেনু আছে বেশ কিছু, যেগুলো ব্রাউজ করলে আপনারা আশা করি আপনাদের প্রয়োজনীয় ইনফরমেশনগুলো দেখতে পাবেন। নেক্সট হচ্ছে গিয়ে আমাদের এই ড্যাশবোর্ডটা। এইখানে যে ড্যাশবোর্ডটা আছে এটা মূলত হচ্ছে গিয়ে ওভারঅল একটা প্রেজেন্টেশন দেওয়া হয়েছে গত 5 বছরের, 2018 থেকে 2023 সালের ইন্ডিভিজুয়াল লেভেল ডাটা, এবং 2014 থেকে আজ অবধি একেবারে অ্যাগ্রিগেটেড লেভেল ডাটা। এখানে ফার্স্টে যেটা দেখানো হচ্ছে সেটা হচ্ছে গিয়ে এই নাম্বারটা, এটা হচ্ছে গিয়ে টোটাল এনরোলমেন্ট, বলতে হচ্ছে হাউ মেনি রেজিস্টার্ড পেশেন্ট ইন দ্য সিস্টেম। সো এটা হচ্ছে গিয়ে একেবারে ওভারঅল রেজিস্ট্রেশন পেশেন্টটা, যেটা মোর দেন 3 মিলিয়ন আছে এই মুহূর্তে। এর মধ্যে উইদিন দ্য কমিউনিটি ক্লিনিক হাউ মেনি পেশেন্ট আর রেজিস্টার্ড ইন দ্য কমিউনিটি, সো সেটা হচ্ছে মোর দেন 1.7 মিলিয়ন। এবং আদার ফ্যাসিলিটি মিনস হচ্ছে গিয়ে ডিস্ট্রিক্ট হসপিটাল, মেডিকেল কলেজ হসপিটাল, এমসিডাব্লিউসি, এই ধরনের যত সরকারি এবং কিছু বেসরকারি হেলথ ফ্যাসিলিটি আছে যেটা এখানে রেজিস্টার্ড আছে, তার সংখ্যা হচ্ছে কি 1.3 মিলিয়ন প্লাস। এটা রেজিস্টার্ড পেশেন্ট, নট দে আর গেটিং সার্ভিস ইয়েট। সো এবার আসি আমরা হচ্ছে সার্ভিসের ক্ষেত্রে। নিচের যে রোটা আছে এইটা হচ্ছে গিয়ে সার্ভিস রিলেটেড ইনফরমেশন। এখানে ফার্স্টে যেটা দেখাচ্ছি আমরা এটা হচ্ছে গিয়ে ভায়া স্ক্রিনিং, যে হাউ মেনি পেশেন্ট আর স্ক্রিন ভায়া। সো এখানে 1.7 মিলিয়ন প্লাস ভায়া স্ক্রিন হয়েছে, যার মধ্যে পজিটিভ পার্সেন্টেজ হচ্ছে গিয়ে 3.1%, এবং নাম্বারটা হচ্ছে গিয়ে 53,150। দেন হচ্ছে গিয়ে পজিটিভ যারা হয়েছে তাদের মধ্যে হচ্ছে কল্পোস্কোপি করা হয়েছে কয়জনের, 35,014 জনের কল্পোস্কোপি করা হয়েছে, যার পজিটিভ পার্সেন্টেজ হচ্ছে 45.2%, নাম্বারটা হচ্ছে গিয়ে 15,000 প্লাস। এটা হচ্ছে গিয়ে এবং কল্পোস্কোপি টেস্ট। দেন হচ্ছে সিবি স্ক্রিনিংয়ের ক্ষেত্রে এটা হচ্ছে টেস্টের নাম্বার, যেটা হচ্ছে গিয়ে 1.6 মিলিয়ন প্লাস, এবং তার পার্সেন্টেজ হচ্ছে 0.8%। নিচের এটা হচ্ছে গিয়ে অ্যাগ্রিগেটেড ডাটা, যেটা আমরা 2014 সাল থেকে আসলে এই কিউমিটিভলি ডাটাগুলোকে কালেক্ট করছি, সেই নাম্বারটা এখানে দেখানো হয়েছে। এরপরে নিচে কিছু স্লাইডিং চার্ট আমরা ইউজ করেছি, যেটা আসলে প্রেজেন্ট করতেছে হচ্ছে গিয়ে কল্পোস্কোপি রিলেটেড কিছু ইনফরমেশন। দেন হচ্ছে গিয়ে ভায়ার একটা স্লাইডিং চার্ট, আপনার দেন হচ্ছে গিয়ে সিবি একটা হচ্ছে গিয়ে ডোনার চার্ট। এটা ডাইনামিক পিরিয়ড দেওয়া আছে, এখানে পার ইয়ার হচ্ছে এখানে এটাকে চেঞ্জ হচ্ছে ডাটাটা। এরপরে এই ড্যাশবোর্ডের একটা অপশন আছে ডাইনামিক এবং 3 মান্থ। 3 মান্থ দিলে অ্যাজ ইট ইজ যেটা আমরা দেখতে পাচ্ছি এই স্ক্রিনে, সেটার জাস্ট পিরিয়ডটা চেঞ্জ হয়ে হুবহু সেম ডাটাটাই শো করবে, যার কারণে আমি সেটাতে যাচ্ছি না। দেন হচ্ছে ডাইনামিক পিরিয়ড আছে একটা, এইটাতে মূলত দেখানো হচ্ছে গিয়ে ওকে। সো এটা আসলে প্রেজেন্ট করছে যে তিনটা, এখানে আমরা তিনটা ডাইমেনশন সেট করেছি এই মুহূর্তে ডাইনামিক পিরিয়ড হিসেবে। আপনারা যারা কল্পোস্কোপিস্ট আছেন এবং বিশেষ করে এই সার্ভাইকাল এবং ব্রেস্ট ক্যান্সার নিয়ে কাজ করছেন, আপনাদের যদি কোনো রেকমেন্ডেশন থাকে, আপনারা যেহেতু অলরেডি এইটা লিঙ্কটা পেয়ে গেছেন, আপনারা চাইলে আমাদেরকে কমেন্ট শেয়ার করতে পারেন। সো উই ক্যান কর্পোরেট হিয়ার। সো যেটা আছে এখানে যে ভায়া কল্পোস্কোপি সিবি, এই তিনটা ডাইনামিক্যালি আপনারা এই তিনটা ডেটাকে আপনারা এখানে অ্যানালাইজ করতে পারবেন, এটা দেখতে পাবেন। যেটা ফার্স্টে একটা চার্ট দেখাবে, এখানে চার্টের নাম্বারগুলো দেখানো আছে বাই ইয়ার। আপনারা চাইলে এখান থেকে বাই ফ্যাসিলিটি দেখতে পারেন, বাই ইয়ার দেখতে পারেন, বাই মান্থ দেখতে পারেন। ওকে, রংপুর মেবি হচ্ছে গিয়ে রংপুর ডিভিশনে, রংপুর ডিস্ট্রিক্ট। আমরা যদি বাই ডিস্ট্রিক্ট দেখি তাহলে আমাদেরকে এখান থেকে সে 2023 সালে আমরা যদি যাই, মান্থ হচ্ছে কারেন্টলি হচ্ছে আমাদের অগস্ট মাস। সো হ্যাঁ, আমরা অগস্ট দেখতে পারি। জি ম্যাডাম, কিউমুলেটিভ ম্যাডাম, এইটা কিউমুলেটিভই দেখাবে, এটা নাম্বারটাই দেখাবে শুধু। আমরা এখানে ইন্ডিভিজুয়াল ডেটা শো করছি না, কারণ এটা তখন আমাদের লর এগেনস্টে চলে যাবে। সো সার্চ একটু টাইম নেবে এটা। এটা হচ্ছে যেহেতু আমরা ডিস্ট্রিক্টটা সিলেক্ট করেছি, তো ডিস্ট্রিক্টের আন্ডারে যে কটা উপজেলা আছে এবং ডিস্ট্রিক্ট হাসপাতালের ডাটাটা এখানে শো করতেছে, এই তিনটা উপজেলা এবং এটা হচ্ছে ডিস্ট্রিক্ট। এটা হচ্ছে গিয়ে সামহাউ কোনো একটা প্রবলেমের কারণে নামটা শো করছে না এখানে, বাট এই হচ্ছে গিয়ে এটা হচ্ছে ভায়া টেস্ট, কোন মাসের ডাটা, কোন কোন উপজেলার ডাটা বা কোথাকার ডাটা। এটা হচ্ছে পজিটিভ নাম্বার, নেগেটিভ নাম্বার। এখানে পজিটিভে আমরা যেটা দেখতে পাচ্ছি যে নামটা শো করছেন, এটা আসলে ডিস্ট্রিক্ট হাসপাতাল হবে। সো ডিস্ট্রিক্ট হাসপাতালে 7টা পজিটিভ আসে লাস্ট মান্থে এবং 48 হচ্ছে নেগেটিভ। উপজেলাতে এই অবস্থা। টোটাল স্ক্রিনিং হয়েছে হচ্ছে 122টা নেগেটিভ হয়েছে এবং 7টা পজিটিভ, টোটাল 129টা। সো একই জিনিস ব্রেস্টের ক্ষেত্রে, জাস্ট ব্রেস্ট ক্লিক করে আমরা যদি সার্চ করি, দেন ফিগারটা চেঞ্জ হয়ে যাবে আমাদের। আচ্ছা, এখানে আমাদের একটা উপজেলা বেড়েছে, কারণ হচ্ছে গিয়ে ব্রেস্টের ডাটা সম্ভবত এখানে কোনো একটা উপজেলাতে এন্ট্রি ছিল না, যার কারণে ওই স্পেসিফিক রোটা তখন শো করছিল না। তো যার কারণে এখন দেখা যাচ্ছে যে ব্রেস্টে আসলে কোনো পজিটিভ নেই, নেগেটিভের অবস্থা হচ্ছে এই 150 টোটাল লাস্ট মান্থে। ঢাকা জেলা, ম্যাডাম আমরা এখানে হচ্ছে কি বাই মান্থ দেখতে পারবো। আপনি যদি যেটা বলেন 3 মান্থের ক্ষেত্রে, ওই ক্ষেত্রে সেক্ষেত্রে আমাদের একটু রিপ্রোগ্রামিং করতে হবে। এটা যদি রিকমেন্ডেশন আসে আমরা নিশ্চয়ই ম্যাডাম এটাকে আমরা নিব আর কি। ঢাকা ডিস্ট্রিক্ট উপজেলাগুলো, এটা হচ্ছে গিয়ে কোনো একটা ডিস্ট্রিক্ট হাসপাতালকে শো করছে। টোটাল নাম্বার হচ্ছে সিবিইতে, টোটাল পজিটিভ সিবি পজিটিভ আছে 8টা, নেগেটিভ আছে 1055, টোটাল 1063। আচ্ছা, সেটা যদি ম্যাডাম আমরা দেখতে চাই, দেন আমাদেরকে হচ্ছে গিয়ে বাই ফ্যাসিলিটি যেতে হবে, ফ্যাসিলিটি গ্রুপ, মেডিকেল ইউনিভার্সিটি। টোটালটা দেখাচ্ছে ম্যাডাম এখানে 877, পজিটিভ আছে একটা। এটা হতে পারে যে হচ্ছে গিয়ে যেহেতু আমরা লাস্ট মান্থ শো করছি, সামহাউ এখন মতো হয়তো এন্ট্রিটা আপডেট হয়নি, যার কারণে ডেটাটা আসছে না। আমরা একটু প্রিভিয়াস মান্থে গেলে হয়তো বা কি অবস্থা। সো এইটা হচ্ছে কি ম্যাডাম এইভাবেই দেখাচ্ছে আপাতত। সো আমরা হয়তো এটাকে চেঞ্জ করে বাই ফ্যাসিলিটি শো করাতে পারি, বাট আমরা যদি ইন ডিটেইলে দেখতে চাই যে আসলে কি অবস্থা, তাহলে কিন্তু আমাদের কাছে DHIS2 মানে র ডেটাবেসটাই আছে, যারা আপনারা এখানে সরাসরি কাজ করছেন। সো আপনারা কিন্তু চাইলে হচ্ছে গিয়ে এই আপনাদের কাছে অ্যাক্সেসও আছে নিশ্চয়ই, কারণ আপনাদের হেলথ ফ্যাসিলিটিগুলো থেকেই ডাটাটা এন্ট্রি হচ্ছে। সো ইউ ক্যান চেক ইট বাই DHIS2. So if you go to DHIS2 by using your username and password, so there are several dashboard there, so that we designed already for you to একটু এটাকে দেখা যাবে। ওকে, সরি। সো এইটা হচ্ছে গিয়ে একটা ওই যে মাল্টিপল ড্যাশবোর্ড যেটা আমি বলছিলাম, যে যে ড্যাশবোর্ডগুলো ডিজাইন করা আছে। হ্যাঁ, জাস্ট আমার মনে হয় আমার আসলে শেষ যেটা আসলে DHIS2 নিয়ে বলছিলাম, যে DHIS2 যেহেতু আপনাদের কাছে অ্যাক্সেস আছে, ইউ ক্যান চেক বাই ইউর সেলফ by using your username password by individual facility. So there are several dashboard. আচ্ছা ম্যাডাম, বাট অন্য কোনো ল্যাপটপ হলেও দেখাতে পারবো আমি, যদি ইন্টারনেট কানেকশন থাকে। ভাই আপনার ল্যাপটপটা একটু দেওয়া যাবে এখানে, মানে এখানে যেটা ইউজ হচ্ছিল। কানেকশন আছে, ল্যাপটপে হয়তো প্রবলেম হচ্ছে কোনো। ম্যাডাম যেহেতু বলেছি একটু অ্যাক্সেসটা দেখাতে, আমি জাস্ট ফার্স্টের থেকে যাচ্ছি। আমাদের এই সফটওয়্যারটা অ্যাক্সেস করার দুইটা ওয়ে আছে। সো আপনি হচ্ছে গিয়ে ডিজি হেলথের অ্যাড্রেস যদি জানা থাকে আপনাদের কারো dghs.gov.bd জাস্ট এইটা টাইপ করলে হবে, অথবা ডিজিএইচএস সার্চ করলে হবে, ডাইরেক্টরি জেনারেল অফ হেলথ সার্ভিস এটা, অর ইউ ক্যান সার্চ বিএসএমএমইউ। ওকে, সো আমরা যদি ব্রাউজ করি বিএসএমইউ, দেন বিএসএমইউর যে ওয়েবসাইট আছে সেটা আমাদের সামনে সাজেস্ট করবে। এখান থেকে বিএসএমইউর ওয়েবসাইটে গেলে একেবারে বটমে চলে যাব আমরা সোজা, আসলে এখানে ডানে বামে দেখার দরকার নেই, একেবারে বটমে চলে যাব। বটমে গেলে হচ্ছে কি ন্যাশনাল সার্ভিক্যাল অ্যান্ড ব্রেস্ট ক্যান্সার সার্ভেইলেন্স সিস্টেম, এই লিঙ্কটা দেওয়া আছে এখানে। এখানে যদি আমরা ক্লিক করি এই লিঙ্কটা ব্রাউজ হতে থাকবে। পাশাপাশি আমি ডিজি হেলথের সাইটটা একটু দেখাই দিই। ডিজিএইচএস ব্রাউজ করলে আচ্ছা, সো ব্রাউজ করে যখন আমরা ক্লিক করতেছি তখন লগইন পেজ চলে আসছে। এখন ইউজার নেম পাসওয়ার্ড আসলে আমি সবারটা জানিও না, আমি আমারটা জানি, তো আমারটা দিয়ে আমি দেখাতে পারি। এরপর হচ্ছে কি আপনারা যখন লগইন করবেন আপনাদের ইউজার নেম পাসওয়ার্ড দিয়ে ঢুকে আপনারা দেখতে পাবেন। থ্যাংক ইউ সবাইকে।
Thank you to all for your patience hearing. I'm requesting speakers and chairperson to take a photo. And then we'll go for short tea break session. Thank you. I would like to inform next rapporteur, please ready for your next session. Thank you.